Hello and welcome. In the really dynamic world of inflammatory bowel disease, let's be honest, pharmacists are right there on the front lines. So think of this explainer as your personal toolkit. We're going to break down the key pharmacology and the counseling points you absolutely need to manage these complex patients with total confidence.
You know, the medication landscape for IBD, it can feel a little daunting, right? You've got your foundational therapies, your biologics, all of it. Our goal today is simple, to turn that complexity into clarity. By the time we're done here, you're going to have a rock-solid framework for these drugs and the most important advice your patients need to hear.
Okay, first things first, a quick but super important distinction. The real difference between Crohn's and ulcerative colitis boils down to one thing: anatomy. A simple way to think of it is Crohn's can be anywhere from gum to bum, while UC, it's strictly in the colon. And this isn't just a fun fact. It's the detail that completely drives our therapeutic choices, especially for locally acting drugs.
So what are we actually trying to achieve here? Our goals are pretty ambitious. We're not just chasing symptoms. We're aiming to induce and then maintain a deep endoscopic remission. And what that means is actually healing the lining of the gut. On top of that, we're focused on preventing those really devastating long-term problems like malnutrition and colon cancer.
So let's start by opening up that toolkit and grabbing the first tools every pharmacist has to master: the foundational therapies. These are our go-to drugs for getting that mild to moderate disease under control. When you're comparing these two, the key difference, the thing to remember, is the sulfapyridine part of sulfasalazine. It's the primary troublemaker. It's responsible for more than 90% of the side effects, like nausea and rash, and it's why we have to worry about sulfa-allergies. Mesalamin, on the other hand, is basically just the active ingredient without that problematic piece, which is exactly why it's so much better tolerated. But we still have to keep an eye out for that rare but serious kidney toxicity.
So when you're counseling, the number one point is adherence. And here's some great news. You can tell your ulcerative colitis patients that once-daily dosing is just as good, which is a huge win for compliance. For active disease in the lower colon, a combo of oral and rectal therapy is way better. But remember this, for Crohn's maintenance, 5 ASAs just don't work. And always stress this, do not stop this medication suddenly because it can definitely trigger a relapse.
Next up, we have corticosteroids, a class that's really all about balancing raw power with precision. You know, prednisone is an absolute powerhouse for stamping out a flare, but its systemic side effects are a huge drawback. And that's exactly why budesonide is such a clever alternative. Because of its high first-pass metabolism, the liver basically wipes most of it out before it can get into the rest of the body. This lets us target the gut inflammation directly, while dodging many of those classic steroid side effects.
The steroid taper. This is a process where we as pharmacists are absolutely indispensable. The number one rule to drill into your patients' heads is that corticosteroids are for induction, not maintenance. They put out the fire, but they are not a long-term fix. A slow, careful taper is crucial to prevent a rebound flare and to let the patient's adrenal glands wake back up. This is one of our most critical teaching moments for sure.
So what happens when those foundational therapies just aren't cutting it, or when a patient just can't get off the corticosteroids? Well, that's when we escalate and bring out the more advanced tools, the immunomodulators.
Okay, thiopurines like azathioprine are real workhorses for steroid-sparing maintenance, but they come with a big, bold instruction manual. First, they are slow. They can take up to 3 months to really kick in, so you'll often see them started while a patient is still tapering off a steroid. Second, monitoring is totally non-negotiable. We have to watch for bone marrow suppression, and TPMT genetic testing can really help us spot patients who are at the highest risk. But maybe the most important counseling point? Sun safety. These drugs increase the risk of non-melanoma skin cancer, so yearly skin checks and being obsessive about sunscreen are an absolute must.
Now, tofacitinib, an oral JAK inhibitor for UC. It offers a much faster onset, which is great, but it demands our highest level of vigilance. Pay very close attention to that Health Canada alert. We're talking about really serious risks here: shingles, cancers, blood clots, and major cardiovascular events. So the bottom line for us is patient selection. We have to be extremely cautious in older patients, smokers, or really anyone with cardiovascular risk factors. And hey, don't forget to monitor their lipids.
And now we enter the era of precision medicine with our most targeted tools yet, the biologics. These agents have completely revolutionized IBD care by zeroing in on specific inflammatory pathways.
The anti-TNF agents, these were the first ones on the scene. For us in the pharmacy, the pearls are all about practicality. With infliximab, it's all about pre-screening for latent TB and being ready for infusing reactions. For the sub-Q options like adalimumab, our job is to become experts in counseling patients on proper injection technique to make sure it's effective and comfortable. But no matter which one it is, TB screening is always step one.
The newer biologics get even more specific. Vedolizumab is really fascinating because we consider it gut selective. Basically, it works by blocking immune cells from getting into the GI tract tissue, which in theory might mean a lower risk of systemic infections compared to the anti-TNFs. Then you've got ustekinumab, which has a unique dual target, IL-12 and 23, and a really distinct dosing schedule that patients need to get right, a one-time IV loading dose based on their weight, then simple sub-Q injections every 8 weeks.
All right, let's shift gears a bit and talk about some of the most high-stakes counseling scenarios we're going to face. Managing IBD in special populations, where the wrong piece of advice can have really serious consequences.
Okay, this slide right here is one you might want to bookmark. The single most important message for a pregnant patient is that active disease is a bigger risk to the pregnancy than most of the medications are. But there are absolute red lines. Methotrexate and tofacitinib are completely contraindicated because they're teratogenic. And for the anti-TNF agents, they do cross the placenta in the 3rd trimester. So a key counseling point is that the newborn cannot receive any live vaccines for at least their first 6 months of life.
This is another area where pharmacists play a vital public health role. For our immunosuppressed IBD patients, the rule is pretty simple. Inactivated vaccines are good to go. Live vaccines are a no-go. And we need to be specific with them. They should get the annual inactivated flu shot, not the live nasal spray. Proactively checking their vaccination status for things like pneumococcus and hepatitis B before they even start these advanced therapies, that's just best practice.
When you put all of this together, it becomes crystal clear, right? The pharmacist's role goes so far beyond just dispensing. We are truly crucial partners in IBD care. Our expertise in monitoring, managing drug interactions, teaching patients about adherence, and making sure they get preventative care like vaccines, that's what drives the best possible outcomes for these people.
And that kind of brings us to our final thought for today. As we move toward even more personalized therapies, with things like genetic testing and drug monitoring becoming more common, our role is only going to get bigger. So the question to ask ourselves is, how can we leverage our unique expertise to help tailor these powerful treatments to each individual patient? That's the really exciting future of IBD management. Thanks so much for joining me for this explainer.